In this upcoming session, we are going to talk about vitamin A deficiency eye disease and Noma. Why these two diseases are chosen is because they are such good illustrations of the ravages of malnutrition, the synergy of poverty, lack of immunizations. The demographics of these diseases are have much in common. They happen in the same populations. They often follow overwhelming infections that would have been vaccine preventable. The the other importance of emphasizing vitamin A is that vitamin A distribution, whether in capsules or sugar fortification, has made a major impact in the incidence of vitamin A deficiency eye disease in places where it's used by the public health people, but also in places where its penetrance is not complete enough. Medical teams, whether they be public health teams or mission teams or people doing work in the community, the distribution of vitamin A capsules in many different systems has a very important role in protecting the health of the community. So that is why we want people to understand the reason that vitamin A distribution has become such an important pillar of child survival. These two diseases happen to children who were born normal at birth, visibly normal, but developed these diseases. Noma on the left, nutritional blindness on the right. The young man on the right is a 16-year-old boy who told me that he became blind after measles when he was 4 years old. And this is the classic story of vitamin A deficiency disease. The risk factors, of course, malnutrition. All degrees of malnutrition are implicated in Noma and nutritional blindness. Even before the child is born, the stage is set for these diseases by maternal micronutrient deficiency. Malnutrition before the 4th month of pregnancy impairs thymic development and results in impaired T-cell immunity. Growth stunting starting early in infancy is a risk factor, and deficiency of micronutrients such as vitamin A causes immune deficiency. Focus on vitamin A. Vitamin A distribution and food fortification has become a standard part of child survival efforts around the world. It saves children's lives, eyes, and faces. The functions of vitamin A, vision, night, day, color vision, also epithelial cell integrity. Maturation of endothelial and epithelial cells requires good vitamin A levels. Immune response, blood production, skeletal growth, fertility, both male and female, and embryogenesis. Now, this is a good time to mention that vitamin A megadose is teratogenic in pregnant women. So the dose that is given to children throughout their childhood and given to an immediate postpartum woman cannot be given during pregnancy. We'll talk about that dosing later. Severe vitamin A deficiency is a widespread problem in Central America, Africa, and Asia, and was one of the reasons that children suffer so many infections. Why do children become vitamin A deficient? Well, mothers of poor children often have vitamin A deficiency and produce deficient breast milk, vitamin A deficient breast milk. Children's diets provide too little vitamin A. Vitamin A is best from animal-sourced foods. Children spend a large part of their childhood being sick. Provitamin A carotenoids in vegetables and fruits are less readily bioavailable than previously thought. Early weaning onto foods low in vitamin A. Growth velocity and therefore vitamin A requirement is higher during preschool age than at any other time postnatally. Risk factor number 2. Recent overwhelming immunosuppressive infections such as measles or malaria that deplete a child's vitamin A stores and affect the eyes and the mouth. Look at the epithelium of the lining of the mouth. the endothelium, the mucous membrane. Risk factor number 3, extreme poverty. Number 4, contamination of food and water with animal waste. Number 5, lack of access to medical care. These diseases can be prevented. Number 1, micronutrients. Here we have a vitamin A capsule being squeezed into the child's mouth, something that is done by medical brigades, public health workers. This is a common. Micronutrients include all of the vitamins and minerals essential to health. Multiple or single supplements such as vitamin A, iodine, and zinc has been shown to play a crucial role in child survival. Vitamin A distribution is part of child survival programs all over the world, prevents infections and improves growth. It's distributed usually every 4 to 6 months to infants, children, and new mothers according to established protocols, which are, there are some universal, but some are country specific. Are Megadose vitamin A capsules safe and effective? A resounding yes. There has been time when they were felt to be too strong, but the studies have shown that they are safe. If the child receives the internationally accepted supplementation regimen, his or her liver stores will still be far short of the average American child and exceedingly below toxic levels. However, the estimates indicate that this standard supplementation regimen will permit a typical child in a developing country setting to attain minimally adequate vitamin A stores during the first 2 years of life. Now, the Megadose capsules, this is the prevention and treatment doses. It goes by age, non-breastfed or breastfed if the mother has not received supplemental vitamin A. A quarter of a capsule or a dose of 50,000 units, 2 drops of the capsule of the 200,000. Breast milk provides vitamin A. And this is the dose that is per age that is recommended for a child who is critically ill who needs the triple dose regimen. So they, for example, an infant of 6 to 12 months, 100,000 units, but if they have Noma, nutritional blindness, severe anemia, severe malnutrition, severe diarrhea, did I say malaria, those kinds of overwhelming infections, measles, those children should get a triple dose, 1 today, 1 tomorrow, and 1 in a week. But the dose is the dose for their age. So for an infant 6 to 12, it'd be 100,000. For a child over 12, it's 200,000, etc. Now, the International Vitamin A Consultative Group, which has now become the Micronutrient Initiative, in 2002 revised the recommendations, and they recommended an increase in what is given to postpartum women and their infants also at 6, 10, and 14 weeks. They felt these doses were improved and safe. They have not been universally accepted. So the revised recommendations are here, but you have to do whatever your Ministry of Health, wherever you are, declares to be their norms of treatment. So, as I just said, in emergencies such as measles, pneumonia, TB, malaria, meningitis, severe diarrhea, severe malnutrition, or when any signs of impending vision loss from nutritional blindness, whether it be night blindness or we'll go through the signs, the Bateau spots, the dry eyes, the Bateau spots, the cornea clouding, the bulging, all of those signs of impending trouble with vitamin A nutritional disease, eye disease, you give the triple dose treatment. This will replenish acutely depleted vitamin A stores and can be life-saving, and also see other appropriate treatments for conditions. Seek all and use all other appropriate measures. But don't wait. Give the vitamin A triple dose immediately if you encounter a critically ill child. The triple dose treatment, again, for the severe life-threatening diseases, 1 dose today, 1 dose tomorrow, and 1 dose in 1 or 2 weeks. Sometimes they say 2 weeks, but 1 week is wiser because you may not have access to the child in 2 weeks. So the 1 to 2 weeks is what is usually recommended. And the vitamin A single extra dose for malnourished children with moderate infections. So not a life-threatening infection, but ear infection, diarrhea, tonsillitis, respiratory infection, parasites, worsening malnutrition. Give 1 extra vitamin A capsule, but don't repeat more often than once per month in the absence of severe infection. What about a pregnant woman with night blindness? Remember that vitamin A megadose is teratogenic. Mother and baby need vitamin A. If you see a pregnant woman with night blindness or any sign of developing vitamin A deficiency eye disease, she needs the megadose. She needs the vitamin A, but not the megadose. It's toxic to the unborn, especially early in pregnancy. 1 drop from the vitamin A from the megadose to 200,000 dose capsule per week is a correct dose in pregnancy. 1/8 of 1 capsule, 25,000 IUs per week. And she should eat liver, eggs, milk, and green leafy vegetables. And if she is following food taboos, which keep her from eating those most nutritious foods during her pregnancy, there should be an effort to share the information that those food taboos are dangerous. Essential micronutrients. Besides vitamin A, there are many other essential micronutrients, vitamins and minerals to be found to be lacking in children who get Noma, nutritional blindness, and other deadly infections. See the hidden hunger PowerPoint. Improving nutrition by better diet in pregnancy, exclusive breastfeeding early in life, and food fortification with complete essential micronutrients will prevent many deaths from childhood infections. Now, prevention number 2, measles vaccine. The nutritional blindness and Noma often follow after measles. And so the vaccine for measles is very and prevention number 3, oral hygiene. Keep children's mouths clean starting in infancy. Number 4, improved diet for pregnant and nursing mothers and children. Number 5, clean food and water. 6, separation of livestock from living space. Many times the baby children and the baby goats are sleeping in the same place. The kids are all bunked down together, and that's not because people want to do that, but because they're poor, and they have to use the resources they have. They can't afford to have their livestock wander off or be stolen, so they bring them into the house. Until these diseases are eradicated, early recognition and early treatment are urgent. Learn the early signs of these 2 serious conditions that affect severely malnourished children. Teach parents to be watching it and ask them to report early to get early treatment. And look at children's eyes and mouths during every encounter. In the proper setting, a child with a mouth lesion or an eye lesion should be considered to have early potential vitamin A deficiency, mouth disease, Noma, or eye disease, and should be treated aggressively to ward off disaster. The early recognition of Noma. Know the context, the early signs and signs of advancing disease. If Noma is not recognized and treated in the early and advancing stages, gangrene can permanently destroy the structures of the face. Early recognition allows time to save lives and prevent devastating consequences to children. Recognize the Noma context. Poor family, poor sanitation, severely malnourished children, and sometimes just a moderately malnourished child. Poor immunity to infection and weak tissues, recent severe infections such as measles. Now these are the early signs. Early sign of impending danger may be an innocent appearing small mouth ulcer or inflamed gums in a malnourished child, but acute necrotizing ulcerative gingivitis ANUG, also known as Vincent's stomatitis or trench mouth, is the usual precursor or presentation. This is a photo from Dr. En-Wan Wu, who has been a close advisor to Mama as we've worked on Noma-related issues. Recognizing the signs of advancing disease and impending gangrene. Cheek swelling, foul breath odor, and anaerobic breath odor, fever, pain, drooling, weight loss. This child is still in a stage where antibiotics could reverse the disease. Early intervention to prevent a mouth infection from progressing Noma. Antibiotics, vitamin A, oral hygiene, nutritional rehabilitation, including essential micronutrients. Seek consultation immediately, but begin treatment without delay. And in case the family cannot get the child to a higher level of care, be prepared to give them enough antibiotics and see them through the short course of the illness. Don't tell them to go to a hospital that is out of their, it's just not feasible for them to do, but not have a plan to see them, follow them up, and make sure that they get a full course of oral treatment if that's all you can offer them. Early intervention antibiotics for Noma. In the community, follow the charts for oral doses and begin the 14-day course of Noma and or amoxicillin or augmentin amoxicillin clavulanate. Why use these antibiotics? Metronidazole and amoxicillin are antibiotics that kill anaerobic bacteria, which are the type that cause the foul odors and deep infections. These germs often come from the family Livestock, but may even be normal mouth bacteria that the child, weak from malnutrition, cannot fight. These antibiotics are safe even in pregnancy, but need to be given quickly and in higher than normal doses when given by mouth in order to penetrate into deep or serious infections like Noma and tissue infections around the eyes, and also pneumonia. Charts for field use help to choose the doses for age or size. Literacy for the sake of community health workers who may need some literacy support. This is the metronidazole dose. You see you can either go with newborn, young infant, older infant, toddler, preschooler, school age, or preteen and adult. And your dose is always 250 milligrams. If it isn't, then you adjust the size of the pill. You go by, in the newborn, milligrams per kilogram. In the young child, you go with a quarter tablet. Older children, a quarter tablet 4 times a day. So you just follow the chart. And also crush the tablets and give them orally. To give a person who doesn't have a refrigerator powdered medication, tell them to add pure sterile water and refrigerate, that doesn't work in this setting. So it's better to use tablets or capsules. You can open capsules and follow these instructions. Amoxicillin high dose for pneumonia, Noma, other serious infections, and high dose is basically the moderate dose. So now, vitamin A deficiency is a risk factor. Supplementation promotes prevention, and the triple megadose. Now we will look at early early interventions with oral. The early treatment, if you will see a mouth ulcer, swelling and redness of the gums, swelling of the cheek, foul breath, and fever in a malnourished child, especially between 6 and 72 months, begin emergency treatment with the vitamin A triple dose, metronidazole, oral hygiene, including zinc-enriched powder. Mama has a dentifrice with zinc in it, and also essential micronutrients, which is food. Now, the later stages are not likely to be something that is being addressed out in the community, but it can be. Once they be aggressive to prevent Noma and blindness, once a mouth infection has become established in a malnourished child, IV antibiotics may be necessary, but try to use the oral antibiotics ASAP in case that is not an option. And if you're arranging for a child to go to a higher level of care, be sure to not believe, unless you see it with your own eyes, that that's actually going to happen. Don't send the parents away with instructions that they may not be able to comply with. So, recognition of nutritional blindness. The first sign is loss of night vision. The children don't run and play in the dark. They go in and perch like a chicken in the roost. So the parents often call them, this child has chicken eyes. Then later the eyes become dry, red, and sore. And then late sign softening of the cornea, ulceration, rupture, and blindness in the eye. So this is the dry eye, and a little bit of foamy material starting to form, but the red and dry eye, that is called xerophthalmia. That's early vitamin A deficiency. Give that child the vitamin A dose right away. Now, the next comes a Beteau spots. This is very dangerous. Do you see the buckling up of the sclera? Permanent blindness may occur if vitamin A is not given immediately following the protein. And caramellation. Now, do you see the cornea is starting to become opaque, soft, hazy, poor quality? This is critical. Now we're starting to get into big danger. Megadose vitamin A according to international norms now. Dose. Now, this cornea has become gelatinous, it's bulging, it's about to rupture. When that happens, the eye will be permanently blind, but there is still a chance that this eye can be saved by 3 doses of vitamin A. Now, this is the same eye, healed by timely vitamin A capsules. The scar remains, but the vision is good in this eye. This eye was saved by 3 vitamin A capsules, which are a few pennies apiece. So these are the stages of nutritional blindness, and each of these children, when encountered, should get the AAA. Even though this child is probably going to lose his right eye, you should still give him the 3 doses of vitamin A on schedule to protect his life and left eye. So even in late stages, a bulging eye may heal with triple dose vitamin A treatment. While arranging emergency hospitalization, give the first megadose of vitamin A, start metronidazole and amoxicillin or amoxicillin clavulanate or other broad-spectrum antibiotic as available. Instill chloramphenicol or tetracycline eye drops 4 times daily to be continued for 7 to 10 days, and atropine eye drops 1 drop 3 times daily to be continued 3 to 5 days. Cover with sterile saline-soaked eye pads and bandage the eye. We had the experience of seeing children like this before the knowledge was out and widespread of the importance of vitamin A megadose therapy in this setting, and played a role in advocacy and sharing the information that eventually helped to improve the treatment norms. So I say that to say that we who have the privilege of being exposed to this kind of knowledge should share it widely, and advocate for change when we see that the benefit of this information has not reached people who would be eager to receive it. Prevention requires attention to the cause of death and disease before symptoms appear, universal access to standard child survival interventions in the village. Timely intervention requires proximity, supplies in close proximity to the villages, well-trained healthcare providers accessible to the villages, families aware that the resources are available to their children, and aggressive case finding of early disease. But we can't think of combating these diseases with case finding. That's like thinking about um, polio eradication by finding cases of children who have been affected, who have been damaged by the polio virus. We have to think of the milieu, the demographics that allow this disease to continue and approach the problem on that very basic level. It is important for everyone who has contact with villages with acute and chronic malnutrition to be aware of these very serious public health problems. From policymakers to parents, everyone should be aware of the crippling and deadly illnesses, and primary village health workers should not only be trained to recognize, but also to prevent and be equipped with vitamin A capsules and emergency medicines to begin timely treatment for all stages of nutritional blindness and Noma. Thank you.